Welcome to Unit 5, Red Blood Cell Morphology, Practical Application, Video 2. Erythrocyte aggregation has been consistently associated with insulin resistance, central obesity, and hypertension. This involves the existence of a low-grade, subclinical, and smoldering inflammatory response in these conditions. Elevated cholesterol associated with insulin resistance in diabetes is seen frequently with patients. Elevated cholesterol induces changes in the erythrocyte membrane. This is primarily attributed to accumulation of cholesterol in the membrane. Any changes in cholesterol content of the erythrocyte membrane changes the membrane property and alters the normal rheologic properties like aggregation, deformability, and shape. 20 to 40% elevation of fibrinogen has been detected in diabetic blood. This can alter red blood cell indices. Insulin resistance is associated with red blood cell aggregation and reduced deformability, both of which result in impaired tissue oxygenation and loss of ATP. Oxidative stress and chronic inflammation are almost always present in metabolic syndrome. The question of do the symptoms match the lab tests should be asked with every lab analysis. It is highly unlikely that a person with a cholesterol of 258 and triglycerides of 373 would wander into the office one day and be totally asymptomatic. Knowing that chronic inflammation is associated with insulin resistance and diabetes, this makes the white blood cells of 5.4 highly suspect as being in, quote, normal range, end quote. This may be an indication of fatiguing bone marrow production of white and red blood cells. This lab brings into question how they can have a serum iron of 228 and a low red and white blood cell count. This lab is indicative of a myelophytesis condition. When a patient has a low blood count, this means their bone marrow is not making enough of one type of blood cells. Bone marrow is a sponge-like tissue inside the bones. It contains stem cells that develop into three types of blood cells that the body needs. Red blood cells carry oxygen throughout the body, white blood cells fight infections, and platelets stop bleeding. Inflammation is a part of the healing process for wounds and infections. Inflammation is a normal immune response that functions to protect the body from infections and diseases. During inflammation, white blood cells and other body chemicals attempt to remove any potentially harmful substance from the body. The body is set up for short bursts of inflammation to combat microbial, mechanical, or chemical insults. This inflammation happens locally at the site of injury, but is guided by the neuroendoimmune supersystem. The whole point is to generate enough inflammation to combat the threat through this acceleratory neurotransmitters, inflammatory cytokines and chemokines, white blood cells, and the vasomotor system, and then cool, repair, and close up the area of injury, ending the inflammation through the inhibitory neurotransmitters, anti-inflammatory cytokines and chemokines, white blood cells, disruption of the NEI supersystem through long-term stress, and the ingestion of inappropriate foods and chemical irritants creates a state of chronic inflammation. Our immune system can become fatigued and work at a low level, no longer able to generate enough energy for full protection, but still cause ongoing cell damage through low-grade inflammation. We become depleted of certain white blood cells, and others continue to maintain the inflammation. If the patient has a history of autoimmune disease and symptoms of inflammation, A lab report with white blood cells in the normal range could indicate that this is the best that bone marrow could produce under the circumstances. Anemia of chronic inflammation is a result of bone marrow fatigue. This lab reports iron of 16 and a low red blood cell indices with high RDW. If iron deficiency anemia is the only anemia considered, iron supplements will support ferrophilic bacterial overgrowth, further exacerbating the patient's symptomatology. It should also be noted that an accurate platelet count was not possible due to aggregation of the platelets. It is highly unlikely that the platelets would aggregate without involving entrapment of red blood cells. This clump would then attract white blood cells. Automated counters do not count individual cells in clumps, rouleau, aggregation, or agglutinations. Iron-loving bacteria gobble up the iron, making the iron count low. Autoagglutination is the clumping of red blood cells due to the coating on their surface by antibodies. The presence of the antibodies, usually IgM, on the surface of the red blood cells is responsible for the phenomenon of autoagglutination. Agglutination can be observed during immune-mediated hemolytic anemia. Autoagglutination activity is known to be a marker of virulence in gram-negative bacterial pathogens, including Mycoplasma, Vibrio cholera, Bordetella pertussis, Neisseria gonorrhea, and Yersinia and Aeromonas species. Pilling, or outer membrane proteins, of these bacteria have been demonstrated to be autoagglutinins. Mycoplasma need to actively seek out areas of high oxygen and ATP concentration. Red blood cells fill both of these needs. Mycoplasmas adhere to red blood cells and do not merely adhere to the red blood cells, but deform them by producing depressions in the erythrocyte surface. Mycoplasmas famously cause patients to produce erythrocyte cold agglutinins and develop symptoms of Raynaud's syndrome. Lab results showing low hematocrit, normal hemoglobin, increased MCV and MCH with decreased white blood cells indicate the possibility of a mycoplasma infection. This will be seen frequently in patients with Raynaud's symptoms, where even room temperatures can induce symptoms. Absolute neutrophils below 1800 and absolute neutrophils below 1500 is indicative of mycoplasma. This is especially important to identify mycoplasma infections since they can immortalize white blood cells. Hypoxia in blood and also low blood pressure specifically stimulates the kidney to produce and release erythropoietin. Erythropoietin stimulates the red marrow of the bones to produce increased numbers of pro-erythroblasts. It also shortens the time period for the maturation of erythrocytes. The increase in red blood cell production leads to an increased oxygen-carrying capacity of the blood. This increased capacity reduces the stress of hypoxia and in turn produces a negative feedback control on red blood cell production. The commonly thought of denominators in blood hypoxia due to a reduced oxygen-carrying capacity are low hemoglobin levels, exposure to high altitude, exercise, hemolytic disease, and damage to the bone marrow. The unspoken of denominators are altered structure of the red blood cells with anisocytosis, dacrocytes, echinocytes, schistocytes causing hypoxia, combined with rouleau, aggregation, agglutination, and autoagglutination of the red blood cells. Bone marrow is an often overlooked aspect of anemias. Patients are shocked and amazed when shown the deformation of the red blood cells. There is an unspoken assumption that the bone marrow always puts out perfectly formed and functioning red blood cells that always retain their perfect shape. Bone marrow is considered only when it becomes life-threatening with a diagnosis of leukemia or aplastic anemia. Anytime a patient presents with chronic inflammation, autoimmunity, sciatic or hip pain not associated with degenerative discs, bone marrow dysfunction should be considered. The evaluation of mitochondrial function is critical to understand how disease conditions alter mitochondrial function. There is a tight regulation of mitochondrial function under normal conditions, where 90% of the total oxygen turnover in the body is due to mitochondrial respiration. If there's one thing that the mitochondria thrive on, it's oxygen. Mitochondria require oxygen to produce ATP in sufficient quantities to drive energy-requiring reactions. Oxygen-carrying molecules such as hemoglobin and myoglobin are necessary to transport oxygen to where it is needed by the mitochondria. In normal conditions, oxygen bound to hemoglobin in the blood diffuses down a steep pressure gradient into tissues as the blood travels through the capillaries. Next, oxygen diffuses into the mitochondria. Areas of high turbulence in the vasculature accelerate the release of oxygen from hemoglobin. In circulation, there is no specific barrier to oxygen diffusion in the blood vessels that prevent oxygen's exit. As a consequence, oxygen continuously diffuses out of the blood vessels in the same way that the delivery of water transported by a leaky bucket is a function of how fast the bucket is carried. Red blood cells become hypoxic after passing turbulence until their next pass through the lungs. Hypoxic red blood cells leave downstream tissues in a hypoxic state. Hypoxia deactivates mitochondria. Upon reoxygenation after hypoxia, there is an initial delay in the return of the mitochondrial function back to normal. Anemias are classified according to the size of the red blood cell, as being normocytic with normal MCV, macrocytic with increased MCV, or microcytic with decreased MCV. In dimorphic anemia, the patient may have two or more multiple red blood cell populations, examples of hypochromic microcytic and normochromic red blood cells. The dimorphic blood picture will look like a dual population of microcytic and normocytic, or normocytic and microcytic red cells, or a mixture of small, normal, and large cells of different sizes and forms. The most common of the microcytic anemias is anemia of chronic disease. A determination of the serum ferritin levels is the initial step for all patients with microcytic anemia. A low serum ferritin level is diagnostic of iron deficiency anemia. However, anemia of chronic disease can occur with low serum ferritin. Acquired microcytic anemia that is not iron deficient anemia is indicative of an underlying systemic disease and is labeled operationally as a microcytic anemia of chronic disease. Both usual and unusual systemic disease may accompany microcytic anemia of chronic disease. As it is possible to have dimorphic anemia with normal blood values, it is also probable that a patient in the office suffering from long-standing health issues will have dimorphic dysfunctional anemias. Anemia of chronic inflammation accompanies aggregation or agglutination of red blood cells. This also involves bone marrow dysfunction with physical symptoms. Their chronic fatigue, hip pain, and gastrointestinal dysfunction are not separate issues, but involve multiple vicious cycles of dysfunction. Most patients with chronic illness are parasympathetic dominant with vasodilation of the abdominal vasculature. Blood flow is stagnant, especially around the weakest organ, leading to increased aggregation of red blood cells. Oxygen and ATP are released, putting the organ in a catabolic state with increased inflammation and oxidative stress. Look for lab markers of elevated cholesterol, LDL, triglycerides, HDL, glucose with low hematocrit to identify aggregation of red blood cells. This does not require all of the markers to be present. Severe aggregation would occur when all the markers are present. Aggregation to a lesser degree occurs when some or all of the markers are not as elevated. What are the symptoms of bone marrow fatigue? The following are the most common symptoms of bone marrow fatigue. However, each person may experience symptoms differently. Symptoms may include low platelets, with signs and symptoms of easy bruising, bleeding in the nose, gums, and mouth, tiny red spots on the skin known as petechiae, blood in the urine, and dark or black bowel movements. Low white blood cells are another indication, and they often experience fevers and chills, rash, diarrhea, and signs of infection anywhere in the body with swelling, redness, and areas that are warm to touch. They also have low red blood cell counts, with the common complaint of fatigue, and they may have paleness of the skin, lips, and nail beds, an increased heart rate. They tire easily with exertion, experience dizziness, and shortness of breath. Aplastic anemia is a disease in which the bone marrow and the blood stem cells that reside there are damaged. This is typically not considered until it becomes life-threatening. However, this condition may never get to the life-threatening stage. This causes a deficiency of all three blood cell types. Lab reports will show low red blood cells, low white blood cells, and low platelets. Aplastic refers to the inability of the stem cells to generate the mature blood cells. Signs and symptoms include anemia with malaise and pallor, and is associated with symptoms such as palpitations. Thrombocytopenia with low platelet counts leading to an increased risk of hemorrhage, bruising, and petechiae. Leukopenia with low white blood cell counts leading to an increased risk of infection, or probably more commonly, an inability to deal with an infection. And finally, reticulocytopenia with low counts of reticulocytes, which are immature red blood cells. This is a lab result from someone with agglutination of red blood cells. The primary markers for agglutination are elevated red blood cells, hematocrit, and hemoglobin. Agglutination renders the red cells more susceptible to phagocytic activity by the spleen and the liver, thus reducing the number of freely circulating red cells and further impairs the blood's oxygen-carrying capacity. Red blood cells bear numerous cell surface structures that can be recognized as antigens by the immune system. Hemagglutination by IgG, IgA, and IgM antibodies is a function of the effective length of these immunoglobulins and the zeta potential of the cells in the bloodstream. Agglutination of cells occurs when the zeta potential is below a critical level. Plant lectins, also known as phytohemagglutinins or hemagglutinins, have been shown to possess a remarkable array of biologic activities. They can bind to erythrocytes simultaneously with immune factors that cause hemagglutination and anemia. Many of the toxic soft lectins are destroyed by the normal cooking process. However, 60% of the hard lectins in beans and legumes survive the sprouting and cooking process. Agglutination by plant lectins causes clumping of red blood cells that is indistinguishable from true hemagglutination. This occurs when the lectins partially dissolve portions of the red blood cell membrane. With the blood type specific lectins, hemagglutination is blood type specific, but antibody response is not truly specific. Pan-hemagglutinin lectins can bind to all blood types. Pan-hemagglutinin lectins are also invisible to immunoglobulin testing. Eating a toxic, lectin-rich diet causes red blood cells to stick together. This is commonly seen in those eating a raw vegan diet or those consuming high amounts of soft lectins while eating immature fresh fruit year-round that has been harvested early to survive transportation to a distant market. The blood cells stick together and cannot carry oxygen or eliminate carbon dioxide. Plus, more importantly, the red blood cells burst. More blood cells must be made to replace the loss. High lectin consumption causes epithelial lining irritation and hypertrophy. They may be unable to make B12 because of the hypertrophy of the stomach and due to improper or inadequate absorption of vitamin B12 from the gastrointestinal tract hypertrophy. Lectins also promote overgrowth of E. coli in the upper gastrointestinal tract. E. coli and other bacteria translocate across the intestinal barrier variables, entering the bloodstream, and promote agglutination. Oral bacteria, such as Fusobacter, entering the bloodstream through bleeding gums, agglutinates red blood cells as well. The consumption of copper and zinc supplements also enhance red blood cell agglutination. A failure to respond is mistaken for continued deficiency of these minerals when it is the combined interaction of the lectins and bacteria promoting agglutination and inflammation causing the symptoms. Autoagglutination is seen to occur in a type of immune-mediated hemolytic anemia known as cold antibody hemolytic anemia. Cold reactive antibodies are primarily IgM, and they react best at temperatures below 25 degrees Celsius, which is 77 degrees Fahrenheit. But they can also agglutinate cells or activate the complement cascade at near 37 degrees Celsius, which is 98.6 degrees, causing hemolysis or vascular occlusion upon exposure to cold. Diagnosis of autoagglutinins can be confirmed by a positive direct antiglobulin test, also known as the direct Coombs test. A schistocyte is a fragmented part of the red blood cell. Schistocytes are typically irregularly shaped, jagged, and have two pointed ends. A true schistocyte does not have a central pallor. Schistocytes are sometimes referred to as helmet cells. Vascular damage causes fragmentation of red cells by two mechanisms. First, the shear forces along the irregular endothelium causes breakage of the red blood cell. Next, the shear forces also cause inflammation of the vessel walls that generate fibrin strands that guillotine passing red blood cells. It is believed that the combination of these mechanisms is responsible for the formation of schistocytes. Excessive schistocytes present in the blood can be a sign of microangiopathic hemolytic anemia, or MAHA, where the most common cause is aortic stenosis. Their presence in the blood is considered abnormal and indicates the possibility of a thrombotic microangiopathy. In particular, one of the two major syndromes of thrombocytopenia purpurea or hemolytic uremic syndrome, with an unfavorable prognosis in the absence of treatment. Markers for the possible presence of schistocytes are increased RDW and MCV with low hemoglobin. Microangiopathic hemolytic anemia markers are the same, but with the addition of elevated creatinine and LDH above 220. On this side, there's an obvious type 2 diabetic condition present. Type 2 diabetes promotes the aggregation and agglutination of red blood cells, resulting in hypoxia of the peripheral tissues, which is commonly diagnosed as diabetic neuropathy. The neuropathy is the result of hypoxia to the nerves, causing nerve degeneration rather than an irritation from some impingement. When the values of hemoglobin, the red blood cell count, and MCV are affected through errors in counting, MCH and MCHC also become normal, since these indices are calculated and are not directly measured. The red blood cells indices become suspect when they do not fit any particular pattern. Her red blood cells are at the high end of the functional range with a low hematocrit and hemoglobin. This likely makes the MCV a false low along with the MCH and MCHC. The patient's symptoms are exacerbated by the aggregation of the red blood cells seen with the elevated RDW and false low MCV that occurs with agglutination. The increased platelets enhance the aggregation and agglutination, further attracting white blood cells to break up the agglutination. Red blood cells shed oxygen and ATP when experiencing turbulence or agglutination. During red blood cell aggregate formation, oxygen is released, making the red blood cells hypoxic and the area around the agglutination hyperoxic, leading to the formation of reactive oxygen species. The reactive oxygen species damage the epithelial lining, requiring cholesterol plaque formation to patch the damage. The elevated white blood cells of 11.7 bring into the question whether the elevation is due to an acute infection or response to the red blood cell agglutination.